I don't think we can say this at this moment in time. What we know is that there seems to be a shorter time between the development of dyskinesia, for example, in women after starting levodopa therapy compared to men. However, does that mean that we should give levodopa later to women, or that we should give lower dosage? At this moment in time, we can really not say anything about that, because the final goal of the therapy is really to control symptoms as far as possible and to keep any possible side effects in check as far as possible. So it's really something that's adapted to the needs of the patient and also to the personal perception and quality of life. And I think we have no information at this moment to say we really need to adapt this. What we know is that women seem to have higher concentrations of levodopa in the blood. So if you give the same dosage to a woman and a man of the same weight and height, so not attributable to physical differences, there seems to be a higher concentration in the blood of women, which might well be connected to the fact that you do excrete levodopa through the kidneys. And excretion through the kidneys of many drugs is slower in women because women have less nephrons. So the little filters that are in the kidneys, there is a lower number in women compared to men. So we know that a lot of different medications are excreted slower in women. However, does the fact that the concentration in the blood is somewhat higher in women, is this correlated? Does this associate with the fact that dyskinesia comes earlier? There is no explanation for this at the moment, and there's really no data that can say, yes, there is a correlation, and hence we should take a lower dosage. So at this moment, it's really, there is no way to say clearly if we need to adapt in one way or another. The question is, of course, how do we deal with other symptomatology that comes in addition, not so much the motor symptoms, the non-motor symptoms? Is there maybe a higher incidence of depression, for example, or anxiety? This seems to be the case. However, here we also have a question about gender aspects. So what do patients report? If we look at the data from the literature, it seems that women report more incidence of diabetes, more incidence of depression, more incidence of anxiety, of inability to do everyday chores and things like this. And men seem to report other more physical symptoms or sexual dysfunction or things like this. The question is, what are women and men expected to report? We know very well that depression in general is reported much less by men. And we also know that the criteria that we have to diagnose depression work really well for women. They don't work very well for men. So is it really true that women have more depression, or is it simply the questions that we're asking don't work as well? So if in the questionnaire it says something like, well, for how many days a week do you feel like crying, or do you feel very sad? In a certain generation, how many men will actually put a cross on that? Maybe they're not going to cry, but maybe they go out and drink too much. So we know very well there's different ways of coping with these symptoms. And so when it comes to the description of all of these, I would be quite cautious also in thinking, okay, what do we expect women and men to report? What is acceptable? Also, the sexual dysfunction is another thing. It's much more frequently reported in men. Is it really less prevalent in women, or is it just reported less? Or do we ask the wrong questions? So I think when it comes to all of those symptoms that are then somewhat treated also, because of course if you get a diagnosis of depression, you might want to treat that. I wonder if we really need to ask different questions also to take into account those aspects. But if it is a yes or no question, I think at this moment we cannot say that we need a different therapy. What we're trying to do is adapt the therapy as best as possible to the needs of the single patient. I think that's the best thing we can do right now.